So hello, everybody. My name is John Wilkes. I have the privilege of being the Chief Executive of the Institute of Health and Social Care Management. And we've got a fantastic evening lined up for you. I do have some important news, which is that Angela Hillary, who's the Chief Executive of Northamptonshire Healthcare, has unfortunately been taken ill this afternoon and is unable to join us. And because it was very late notice and Angela really wasn't well, so she was not able to organise a replacement. But that notwithstanding, we're very privileged to have the one and only Marr OBE, Chief Executive of the fabulous St Helens and Knowsley NHS Trust, as one of our guests this evening, and the other guest, Professor David Loughton CBE, Chief Executive of Royal Wolverhampton and Walsall Healthcare NHS Trusts. All of these organisations, needless to say, are our much admired regional hubs for different areas of the country. And we are thrilled to have both Anne and David with us. And in the chair, of course, the one and only Roy Lilly. So without further ado, I'm going to hand straight on to you, Roy. Thank you very much.
John, thanks very much, and good evening, everybody. If you're watching us live and you have a question, just drop it in the chat box and we'll find time for some questions at the end. Please don't go away from here thinking, do you know what, I really wish I'd asked that question, right? So don't lose the opportunity. No question too simple, and no question too daft. Just ask whatever you want to ask. Our best wishes to Angela if she's going to watch this later on. I hope you're feeling better. Right. Well, Anne, David, good evening to you both. You're both looking relaxed and, clearly life is treating you well. Plenty of money in the NHS, lots of time, very relaxed job. I can only say this because I'm not within punching distance. I know. Just for the people that won't quite know what your hospitals are like and all the rest of it, let's just get a kind of a little brief vignette of what your hospitals are like, your catchment areas and things like that. And shall we start with Anne? And of course, you're in the middle of merger mania as well, which doesn't help.
Yeah, that's right. So I'll just have to add to John's introduction that I'm also Chief Executive of Southport and Ormskirk Hospitals as well. So not to leave them out.
No, there's two desks, Anne.
Yes. Well, I've got three because I'm doing the provider collaborative as well. So
three desks, Anne. Yeah.
3 hats anyway. I don't know about 3 desks. So as you can see, Whiston Hospital is our hot site at St Helens and Knowsley, and that's as you can see a beautiful PFI constructed building, and we've got a cold site as well. And Southport and Ormskirk have obviously got 2 hospital sites, which is Southport and Ormskirk. It's in their name. So I guess just focusing on what St Helens Knowsley is like, a very deprived population, sort of 800 inpatient beds, hot site, cold site, we're an outstanding trust, so we probably don't have as many. We probably have a better recruitment situation from that point of view than some places might have, because obviously that all does help. But Southport and Ormskirk requested our help about 2 years ago, and for the last 18 months we've been running both trusts, so maintaining their exec team, but I'm the accountable officer for both organisations, and we move steadily towards a day when hopefully there'll be one organisation, and that's work in progress at the moment, as Roy mentioned. So it's a bit of a geographical gap between us there at the kind of extreme north of the Merseyside patch, and we're kind of over in the east of Merseyside. So we kind of surround Liverpool on all sides except the sea. And so it's been an interesting experience, but a good experience. I've enjoyed the time we've been working together with Southport and Ormskirk, and for sure we can learn from each other, and we'll continue to do so. So I guess, but just in terms of how things are, absolutely unprecedented times. Obviously we've never known anything like the levels of occupancy. We're every day more than 100% still after, we've had the COVID crisis and we've had the winter crisis, haven't we? But we're still over 100% occupied, and trying to maintain, quality, safety and patient experience levels and staff morale when you've got all that going on. You know, we've got massive waiting lists, as everybody has, you know, huge morbidity out there, and that's why we're so busy. We've got you know, the cancer backlog, but unprecedented cancer referrals coming through, like, you know, 150% in some tumour sites compared to before the pandemic, still now, that we need to deal with. So, you know, huge problems to deal with, and the hospital's absolutely full. And obviously we have the problem everyone's got with patients not meeting the criteria to reside, but with all of the intractable problems that go with trying to make some progress with that, and put that together with, you know, the workforce situation, the industrial action situation, and the financial situation. And you know, probably it'd be hard to go back and think of a worse time than this in terms of very, very many years I've been doing this job.
You've been around a long time, man. It is bad. I mean, I cast my mind back to 1999 when we had a big flu epidemic then, and Labour had just come in, and we had a workforce problem, all the rest of it. The solution then was Gordon Brown gave the NHS, I think it was about $6 billion to sort itself out. Big chunk of money. But it was, but I think this is, as you say, much worse. David, how are things for you? How's Walsall, the calm waters of Walsall? Wolverhampton, sorry. Wolverhampton.
Okay. I mean, good evening to you all, first of all. You know, I'm not going to repeat what Anne has said, very similar issues. I mean, I've been chief exec in Wolverhampton for 18 years. And I've been chief exec in Walsall Healthcare for 18 months. And as Anne says, it's been a really sort of difficult period. And in many ways, COVID was the easy bit, because generally speaking, we worked our way through it. But obviously, substantial numbers of delayed transfers of care have put pressure on coming in every morning to, you know, minus 60 beds. In terms of admitting patients from A&E. I think the one good thing that I would say, we are, and certainly Walsall Healthcare, its ambulance turnarounds is always in the sort of top 20 best in the country. And both in Wolverhampton and Walsall, I manage community services, and that has been a blessing really, because I've been able to ramp up, you know, hospital at home. And, you know, without sort of 220 patients in hospital at home, that would be 220 beds that we didn't have. So that has really, really helped. And I think also that, you know, as Anne said, it has been a really difficult period. And I've spent a lot of time looking at the, you know, community care issues, social care issues. And, you know, it's staggering the number of vacancies that are, you know, in Wolverhampton. I'm talking of sort of 900 vacancies. 40% of staff are on 0 hours contracts, and, you know, recruitment has been difficult. So I'm not criticising anybody. You know, when you look at the pay rates for domiciliary care, you can get paid £3 an hour for stacking the shelves in a supermarket. So I think that, you know, that's where I'm turning my attentions now, to working with colleagues to see what I can do with staff banks for nursing homes, domiciliary care, etc., etc. So, as Anne said,
the same huge challenges really across the board. Let's sort of.
Well, it was, to be quite honest, Roy, and I mean, I've been a chief exec for over 30 years, and, you know, I'm driving to work one morning and I hear someone on the radio talking about 160,000 vacancies in social care, and I said to all my directors, you know, what's our proportion of the 160,000? And none of us really knew. And when I started to dig into it, that information is readily available. You know, I could find that for any area in the country, and it was sort of staggering to see the numbers. And you're talking about 1,300 turnover, 1,300 turnover in a year, and 900 vacancies. And the numbers I'm giving are only to March 2022, because they're only published once a year. So I'm really keen to, you know, if I'm going to sort out the front door of A&E, I've got to sort out the back door. And I think that that is really incumbent on all of us to do what we can.
It is, and I think, Anne, one of your backdoor solutions, if I can put it like that, is you've taken over a hotel, haven't you? Or you booked hotels?
No, it's not a hotel. We've taken a care home.
Yeah.
And that
What did you buy it, or did you just block book it, or what have you done?
We're leasing it so it was a care home that had space in it because it had space in it. So we've leased it. We haven't bought it.
Yeah.
On the grounds that, if we had to buy it, we probably would have done, but we didn't have to buy it, we could lease it. So we've leased it, and we've transferred patients over there to go and redevelop. The big trick is to make sure that doesn't just clog up, that we get discharges right from there. But there's a bit of a reablement package involved to try and get patients back into the best conditions so that they, you can reduce the level of care. There's kind of evidence to suggest, isn't there, that if you do that reablement, patients don't need as much care to go back, whenever they came from their own home or a home or whatever.
We used to call it convalescence.
Yeah, reablement's the word now. So
we can't say convalescence anymore, can we?
Reablement. So,
yeah.
And I'm just respecting what David was just saying then about staff banks and things. I mean, we did a scheme a few years ago whereby we did reablement people going into people's houses, so a bit like a domestic care package, but it was called a reablement package, so it wasn't that. But the trouble with it is, when you advertise the jobs, what you get is all the local care workers applying for the jobs. So you can even see from just the applications that you're just taking people out. So you're not really helping the situation. And the trouble we found with that, even doing it as a bank level, you're just taking people from the sector they were in before, which you're trying to support, but you can't undermining it at the same time, because we're obviously, the NHS is paying more than local government or the independent sector for their wages. So it's a really difficult balance between trying to do something that supplements the care there without undermining the care while you're doing the supplementing of it.
Yeah,
it's quite a tricky business, really.
Do you think? I mean, but I'll ask both of you really. Perhaps I'll come to you, David. I mean, now we've got the 12th big reorganisation that I remember. We've now got the integrated care boards, which, in theory, look as though it might bring health and social care closer together. We've got the extension of what is really the Better Care Fund, the Section 75 funding and all this. Is that likely to make any difference, or are you still just kind of scrambling to sort stuff out for yourselves? Is this going to be a system-wide improvement, do you think?
Well, I'll say at present we haven't seen it, but there are organisations establishing themselves, and I've been around long enough, Roy, to know when you have these sort of reorganisations, you don't see the benefit immediately.
No, and we're likely to see them torn up if Labour gets in. What do you think, Anne? Are you seeing any? The grass shoots, the new green shoots.
I mean, you still hit up against that thing about the different funding systems, don't you? So although, there was a bit of a model going on between whether the NHS got the money or social care got the money, in the last set of allocations, and there was a bit of both going on, wasn't there? But when push comes to shove, at the end of the day, the local authorities who are, paying for much of the social care, I've got these very rigid, financial rules about, having to set balanced budgets and not overspend and stuff like that. So there just comes a point where they exhaust their ability to do things with all the cuts they've suffered. And so just getting together with the ICB on its own doesn't really solve that problem. So you seem to have endless conversations whereby local government keep reminding us that we have a complete, different set of financial rules in the NHS than they do. And they obviously think it's all very slapdash in the NHS, and one can see why. But we're still hitting up against that. So when money gets made available and it's like given to the NHS to spend on social care, we've had a little bit of that, haven't we? That's one thing. But fundamentally, the underlying problem is they just can't afford the level of social care that they is being demanded from them, and they just haven't got the money to do it. So just bringing them together and hoping it all gets fixed isn't going to fix it. So what we're seeing is, nicer conversations, better conversations, more conversations going on, ideas being exchanged and all of that. But as David says, I don't think we've seen any practical outcome from that yet. It maybe we get some outcome from it, but until we solve the financial problem, it's not really going to solve the problem, because You
And
know,
the other
the other
thing, Anne,
thing-
is you get money too late, don't you? I mean, there's that
well,
meeting in Downing Street the other Saturday or Sunday or whenever it was, and was it 250 million or 500 or whatever?
Well,
it was.
5 minutes.
It was 500 million that was put in on the beginning of December, which is a bit late, isn't it?
Yeah,
And
being
then,
rebadged, and you
then
can't. And what do? You spend it and put inflation back into the system. Yeah, it's not good. Okay, look. Well, I mean, let's sort of kind of reel this back a bit to give people a flavour of what it's like to be in your job. Just take us through like a typical day. What you arrive in the morning. Well, what are your first numbers you look at? What are your key indicators? How do you, and you're running on separate sites, well, you both are. How do you give us a flavour of your day?
Well, I mean, the thing for me that most obsesses me is the occupancy level, because obviously when you come in and there's 60 patients in A&E and not a single bed in the hospital, 60 patients who've been admitted, I don't mean 60 patients who are waiting for, the A&E process to be completed, but 60 patients who've been medically admitted, say, and there's just not a single bed in the whole place. And it's like, you come into that, and so people are arriving in, and that's what they're contending with. And the patient experience from the point of view of being one of those patients who are bedded down in A&E, or one of those patients who can't get in A&E and therefore are in a corridor, as like David, we don't really hold the ambulances up in the way that some do. But that just means you've got loads of patients in. We've only got 34 cubicles, so 60 patients waiting to get in a bed means we've let more than the cubicles have got, double deckers in, double decker beds in the rooms. It's not where you want to be. And I'm also really anxious about what that means from a staff experience point of view. It's no way, to spend your days trying to deal with all of that. So, and we've tried to put every measure, you could think of to try and make that better, in terms of how we've managed that, which I can talk about a bit more later if you want. So that I start with that, what are we going to do with that kind of thing, that occupancy level. And then, how are we going to, get how we do with the discharges, discharges of our own. So the pathway zeros, and as well as the others, where are we at with that, and sometimes it's good and sometimes it's not so good. So it just feels like that constant pressure all of the time. Every day, it's just another version of the same thing as the day before, which is there's just more patients than we've got the capacity to deal with. And we're all running wards in A&E, in effect, and trying to make that safe while we run a ward in A&E. And that argument about where's the money, so we're spending money on all these acute beds with patients who could be in cheaper beds, but that kind of, we haven't got to the point where that's flows enough that we can find a way to overcome all those problems I described before. So we start with that, and then it's like, obviously I've got all these different sites to worry about as well, and I worry about all of them, and what OPAL level are we at today, and what OPAL level should we be at, and can we keep all the electives we've got booked in treated today, if we've got safer staff and things on all the wards. So it's just this constant, like, almost rationing of things to make sure that we can do as much as we can do, but we can do it safely. And, making sure.
I guess it's the same kind of thing for you, David. You've got your key indicators you look at when you come in, and I suppose really the day dictates itself from there.
Yeah, I mean, I think the same as Anne. I mean, look at the ambulance report. That sort of tells you how things have been overnight. Because I mean, I see it as absolutely vital that we do turn ambulances round, because when you look at, some of the times, 57 minutes for a category 1 was, I think, the worst. That's pretty awful, isn't it? And of course, the two things that I think are the main drivers of public dissatisfaction in the NHS over the last period has been fear of getting an ambulance when you need one, and face-to-face contact with GP seems to be driving very heavily in terms of the satisfaction overall in the NHS. So, I mean, in Wolverhampton, I built a 17-bay ambulance receiving bay, which isn't exactly the thing that you would want to do, but it did sort of relieve the pressure. I think it is actually worth saying, though, we shouldn't get this too out of proportion, because there was a bad period, beginning of January and lasted about 3 weeks, and it's settled down a bit more now. So, and you know, I've done this job for long enough. You can always guarantee that the first week of January is always going to be pretty bad. It was just worse this year than I've ever seen it, which is exactly the same as Anne has seen it, and we're geographically in different places. This was happening across the country. I think the other thing that I really ought to emphasise, because, you know, in the briefing I got before we started this, one of the questions was going to be, you know, how have we managed our way through the crisis? I think as leaders, the most important thing is I don't have a crisis, right? That, you know, we've got to manage our way through, work our way through the problems, but it isn't a crisis. I think I'm in a crisis right now because, you know, in managing the organisation, I've probably got the wherewithal to do most things. The crisis I'm in at the present time is the cost of living crisis, because there's not a lot I can do about that. You know, I mean, I have set up food banks for staff, providing free tea, coffee and toast, and the toast is going down really well. And if you'd have said to me 3 years ago I'd be setting up food banks for my staff, I'd have said you're having a laugh.
Running a grocery store and a cafe,
yeah, you know, and that is the bit that bothers me the most, because I have not got the wherewithal to do anything about it. You know, we've got loan schemes in place because I've tried to, you know, stop people going for payday loans and this sort of thing. And I think the other thing that I would say as well, you know, it's not just the people who are not paid particularly well in the NHS that are suffering with the cost of living crisis. You've got some middle managers and middle earners who are suffering just as much, because they're not as old as you and I, Roy. You know, you and I can both remember interest rates and mortgages getting to 16%.
Yeah,
we've actually got a generation of people now who have known nothing but relatively low interest rates, so it's hitting them hard as well.
And their financial circumstances are geared to those lower rates. And what do you, I mean, on this sort of the softer side of the HR equation with your staff, are you doing the same kind of thing as David?
Yeah, absolutely. It's and you know, lots of psychological support service and things like that. You know, we have a 24-hour helpline. You can ring. You know, people just pick up and ring. You don't need to go through any kind of referral process. That's available. We've got, you know, debt counselling, we've got food bank things, you know, we've got, it's like you just got to run everything to make sure that however the stress manifests itself, you've got something that people can go to. But, you know, even running things like, you know, we do Tai Chi classes and things like that, you know, whatever it is that people find helps them to deal with all the pressure that they're under, both, you know, in the work lives and the home lives, is try and think of everything. So yeah,
it's interesting. That is interesting, because I spoke to a group of nurses, you know, and when the strike thing was first in the offing, and it was on the picket line. Actually, I was on the picket line outside St Thomas's Hospital, and you know, as much as money was an issue, and it is, I'm not saying it isn't, but there were things like flexible rotas, creche, car parking, hot meals 24/7, all of that kind of thing that, you know, still a lot of our trusts and our colleagues don't get into that space. And that seems to me to be fairly simple to do.
You've got to do.
Flexible work thing's a problem, isn't it? Because, you know, with the workforce crisis being as it is, you know, it would be so nice to be able to be as flexible as the staff would want us to be. But, you know, you can't have always chasing your tail around, filling the shifts and making sure you've got safe staffing levels and all that kind of thing. So I suppose if there's one thing I wish I could do much more of, is to be able to be more flexible than I'm finding it possible to be, just because it's this kind of constantly trying to make sure we've got everywhere staff that needs to be staffed. I wish, you know, the one thing I feel like I can't do that I'd really love to do would be to do more of that, because I just feel a bit like hamstrung by trying to make sure we've got that balance between, you know, the staff experience and the safety for the patients. But so there's all those other things you can do, but there's some things that, you know, I'd love to be able to do some more of that, really.
So David, sorry, I'll come to you, David. Also the issue, I mean, that's the strike. I mean, the derogations were the big issue, weren't they? You were able to negotiate them locally. The RCN got pretty upset with the liberal interpretation of derogations locally, and in the round of strikes that have been suspended, they were saying that they were going to take the derogations and do them all from the centre in their gold command, which I'm not too sure about where that would stand legally in trade union legislation, because they're supposed to be negotiated with the employer. And as there are 129 employers involved in the strike, they'd have to do 129 lots of negotiations. But how did you, what was your approach to the derogations, David?
Well, I didn't have a problem because we didn't have anyone on strike.
Oh, right. I'm sorry, but that's right. I'll ask Anne. Yeah.
The ballot didn't reach the threshold.
No, that's in. And what about you? Where were you on it?
Well, we spent loads and loads of time negotiating derogations. It was hugely time consuming as a process. And the trouble with it is they don't really stick. So you might have negotiated a derogation, but it just depends whether the staff actually stick to it, because you've got there's no redress, so the fact that the union might have agreed a derogation, the staff may or may not go along with it. And so there was always still that you might have agreed it, but you still didn't quite know what was going to happen until it happened. And then lots of chasing around, trying to get people, if we were expecting them to come in and then they didn't come in. And the unions didn't really see it as their role to try and address that, so they'd say, oh yeah, well, you've got to have whatever kind of level of staff in. Then if the staff just didn't come because they were on strike, that was it, so it was a huge time consuming process, and then not always delivering what you expected it to deliver.
David, talk to me about waiting lists. I mean, the NHS, there was that kind of there was a bit of a calmer period, wasn't there, when COVID sort of looked like it was tailing off before the flu thing started, and you got stuck into the 2-year waiters, I think it was, and there was I was 1-year waiters, wasn't it? 78 weeks. I mean, the numbers really came down quite quickly, because a lot of people don't understand that the waiting list is comprised not only of people that need a new knee, but about 60% of people who just need some kind of a diagnosis or a scan or something or other. So you can actually make a big dent quite quickly if you get a clear run at it.
Yeah, I mean, I'm exceptionally fortunate that as part of the breakup of Mid Staffordshire Foundation Trust, everyone's heard of Stafford Hospital, but nobody's heard of Cannock Hospital, and Mid Staffs consisted of the 2 hospitals. So I acquired Cannock Hospital, which has now got 10 operating theatres, 6 wards, and it's got no emergency medicine, it's got no A&E. So throughout, I was able to keep going. And I think that has really impacted on where we are at the present time in terms of waiting lists. And I'm a real big fan of trying to get to a place where you've got, elective centres. And I've spent pretty near £100 million on Cannock Hospital. And it is a fabulous elective factory, much more productive, because, consultants don't get called to A&E to see anybody. They just go there and get on with the work. So
it is good. I mean, hubs are the new big sexy word now, aren't they, in the NHS?
Yeah, but the other thing, throughout COVID, I was very clear that I kept cardiac surgery going, elective cardiac surgery, because cardiac surgery, if you don't keep the electives going, they just turn into emergencies. And when you look at the mortality from cardiac surgery, it's about 1.something% where you were looking at COVID in the mortality. So it was really important to keep that critical work going, and the same for cancer as well. But as I say, we will achieve the 78 weeks there or thereabouts. But, let's be clear about it. The waiting lists, the numbers at nearly 8 million, that's back to where it was, in the late 1980s. And then, of course, as we all remember, there were all the independent treatment centres built in the days of Alan Milburn being the Secretary of State.
Excuse me.
It is pretty awful, the level of waiting lists, and it's not going to be a quick fix.
No, it isn't. How are you managing, Anne?
Well, as like David, we had a coal site which we managed to keep, let's call it green, during COVID. So nobody ever went on the site that hadn't been tested, either staff or patients. So we were able to keep the cancer surgery particularly going, and indeed did some other trust cancer surgery there as well, because it was so safe. So I think these trusts who didn't have a cold site, a cold elective site, would have struggled a whole lot more, because obviously with COVID, as it was during the height of the pandemic, you couldn't really take those risks. So might be useful just to say a little bit about what we're doing, is it provides a collaborative in terms of managing the kind of whole Cheshire and Merseyside thing, which is the ICS we're in. So we've got 13 different trusts in our provider collaborative, so 13 acute trusts. So we've got this kind of weird scenario in Merseyside, particularly, whereby we've got loads of specialist trusts, and the thing is that means there's 13 different trusts that we're trying to coordinate. So the sort of territory we can't occupy, so we're not tripping over what the ICS are doing, is we've been very focused on the elective recovery stuff, and in terms of actions then, so we've opened a number of surgical hubs where there weren't cold sites, so we've invested the money that was particularly set aside for the capital to open hubs, and of course they're now opening, so it's not like we've taken a long time to do, because often it was something that was being converted or whatever. But we've done a lot of work on things like productivity. So it's like take diagnostic productivity, obviously big problem with both upper and lower GI cancers with the diagnostic process. So what we've done is we've kind of done initiatives like we have the 12-point thing, whereby you'd have to get 12 points. So each type of scope has got a number of points attached to it in terms of how long it's supposed to take, and we're trying to get everyone up to the same level of 12 points. And that's all being led by people, professional, clinical professionals. So it's not like we're doing it like managers, it's the clinicians themselves, and it's about showing others how to get to the best, and that's gone really, really well. So we've managed to really increase what we've done, because the philosophy is, there's no point in opening a load of new things when we're not getting the most we can out of the things we've got. And if some places can do 12 points less than others, we're doing 6. We need to get the 6 up to 12. So we've focused on that kind of thing, and also theatre productivity. So we've got a training programme where somebody from every trust gets trained in being a theatre productivity champion, with all the different techniques that they use. And again, we've got access to advice from the trust that do the best about how on earth they manage to get all those cases through when some trusts don't. We've done a lot of that, and we've got a great big mutual aid hub where people can offer mutual aid but also request mutual aid, so that there's a whole brokerage thing going on, so that we actually do deliver mutual aid and patients move, and we've even got transport for them, patients in place. Lots of work on things like reducing demand through optimization of patients, through advice and guidance, through the PIFU setup, so that we're trying to create space. And so what we've tried to do is do all of that. So, as Dave says, we know we should end up with no 78-week weeks now, and we'll just, but it's gone really, really well. So in terms of, do the provider collaboratives add value in terms of that kind of venture? I think it really has added huge value that we've been able to increase our productivity, and you can see as an ICS, the productivity has, we've climbed up the productivity.
Productivity is quite a tricky thing, Anne, isn't it, really, to manage? The word itself sets hackles up. You talk to a nurse who's just come off a shift about productivity, and you're likely to end up in A&E. I mean, you can kind of see that. You do have to focus it around being the best or best practice or something. It's not easy to manage, is it? I don't think it is.
No, it's not. But I think everyone's worried about how many patients we've got waiting. I think people can kind of see the benefit that if we can get more patients through on the list we've got staffed and available, that we can reduce the waiting time for some people, because I think people are quite empathetic.
It is. I think it's a source of pride as well. David, how do you cope with the P word?
With the what word?
The P word, productivity.
I mean, I think, if you look at the model hospital stuff, it is very, very varied, and it's varied amongst.
Girth. Yeah. You refer to girth at all?
Yeah. If you take, I'll just take an example. If you take ophthalmology, there are differences between individual surgeons, and it's just talking through and working that through. But in a lot of cases, the productivity isn't down necessarily to the individual surgeon. You know, an awful lot of it is organisational things that we can actually change to actually improve. And I think that it's working through it and, you know, looking all the time at what the best rates are, you know, heavily into day case hips at the present time. But that isn't applicable for everybody.
Can't do it with everybody, no. Talk to me about, David, talk to me about the virtual ward, the, you know, sending people home with an iPad, that kind of thing. I would be very nervous about that, but what do you think?
I think it's brilliant, actually. And I think the other thing about
do they keep the iPad or they have to give it back?
Well, we have to, I won't go into details. We get some of them back. But, you know, it's worked out really well, and people are generally quite happy with it because, you know, a lot of people don't want to be in hospital, and providing you put a really good wraparound service and they feel that there's somebody there 24/7 that they can talk to. Because I don't know about you, you know, I do get a bit worried actually with all sorts of things with, you know, answer machines and artificial intelligence and no human being at the end of it. I mean, I won't name it on this, but, you know, I've just had an issue with a bank, and, you know, I just wanted to speak to a human being. So I think you've got to have it as very, very, you know, patient-centred in terms of people feeling comfortable with it. But the other thing about hospital at home, you've got to have real commitment from the doctors and nurses that are delivering the service, and they get really excited about it. And, you know, if you'd have said to me 2 years ago where we would have got to today, I probably wouldn't have believed you. And it is the enthusiasm.
It is interesting, isn't it? It requires, I mean, I think the people who conceptualized this thought that they could probably supplant a technological solution that would require a skills level that would be cheaper and quicker and all that. Actually, it's not quite like that, is it? And you and I know you're doing, you need really, as David said, a very high level of commitment and a lot of skills and experience to spot problems coming. Because otherwise you end up on a Friday night handing everybody over to the community nurse.
Yeah, that's right. I mean, they're not simple things. I mean, I think there are some people who think, you know, it's just you know, people at home with their saturation monitor on or whatever, you know. No, you do need very skilled people. You need to be very clear about your patient selection, and you need to be very clear on the protocols that need to go with it and the technology that needs to support it. But most importantly, as you say, it's about the skill of the people out there who can, because obviously there's a bit of monitoring from in the hospital, but you've obviously got to have people out in the community as well. And you know, we David, I think, mentioned before about, you know, who runs community services. It does feel much more comfortable to me when you're kind of running the community service as well. But we serve 3 different boroughs, and we do the community services in one borough, but not the other 2 boroughs. And so I've always got that slight anxiety about, you know, making sure that all joins up properly. It's all well and good when we run the community services as well, but it gets a bit more complicated when you've got other organisations, you know, who only do community services, running the virtual, being there, you know, needing to be the ones who support the virtual wards. So it's, I think it is more complicated than some people think it is.
I'm sure it is. The IHM ran a panel discussion when it first started, and if you're a member of the IHM, you can get a download of those discussions, and it's a simple document about 26 things to remember to do. And what came through very clearly was that this is not for the faint-hearted, and it's not for the inexperienced. You've got to do it properly. I'm just conscious of the time because I want to make sure we leave some time for people to ask questions. And there's a very good one from Diana Lewis that we'll come to in a minute, but what's you like, and this, I feel this is a bit facile to ask really, but what's your biggest worry really now? We've got COVID's on the way out, the flu's on the way out, the strikes, well, who knows? I mean, they might fizzle out. I don't know. What's your biggest worry?
I suppose my biggest worry is the workforce, because, you know, whatever comes of this pay settlement or not, you know, people are feeling, you know, really, really disgruntled the lot. We know what the labour market's like, and it just worries me that there's people who will have the option to either, retire, do something else, just have a career change, reduce their hours, whatever. That we to see, if this doesn't go well, that we might have another step downwards, if you like, in terms of workforce before we've been able to recover it. Yeah. And the continue, whatever is going on with this morbidity thing, where we've got all these loads of people presenting to secondary care, you've got the kind of demand holding up. As David said, it's not as bad as when we had the flu crisis and the COVID crisis all at the same time just after Christmas, but still there just seems to be more demand out there, and backlog. And I'm worried that we've got all that going on, and we've got this thing, it's quite fragile with the staff. So that's I suppose my biggest worry, because the staff experience is, not what you'd ever want it to be at the moment. It can't be any, there's no joy coming in if you want to give great care to people, and perhaps at times feeling like you're not able to.
What about you, David?
Yeah, agree with what Anne has said. One of the things I'd say, my vacancy rate is 4%, so not in a bad place.
That's very good, actually.
Not in a bad place. Done really well with international nurse recruitment.
Is that sustainable, David? Do you think that's sustainable?
Well, I do international recruitment for a number of NHS organisations, so we've recruited about 3,000. Yes, it's sustainable, but is it necessarily for the long term? I think not. And my worry at the present time, and I'm not having a go here, the numbers of people going into nurse training has just gone down.
It's gone down by 23%.
Yeah, well, we will, once we've got these pay disputes out of the way, and I believe the staff deserve a good pay rise, so I need to say that first. But, when you see people on the picket lines saying how awful it is, the pressure they're under, little wonder that people don't think it makes
it very difficult. And what's going to happen, David. There's probably 5% in the Treasury for an uplift, and they're going to try and push it to 7 or 8%. And what the government are going to say? They're going to say, well, we'll find 5%. You've got to find 2% from efficiencies. You've already found the difference between 3% and 4.5% or 4.75 for this last lot. It's cost the NHS £2 billion, because every 1% costs trust globally £1 billion. Can you do another increase?
No, I don't think we can. I think the really key thing here and Anne said it as well, going forward, the NHS will need to be able to recruit the workforce, because the demands just keep going up, and I can't see that changing in the long term. And workforce is the top priority, and obviously the pay disputes need to be got out of the way one way or the other.
Well, it's politically toxic. It's really difficult. Sorry, David, for cutting you off. I've just got an eye on the time. Forgive me. And I imagine you're just going to say I agree with David if I say it's an internal 2%.
Yeah, well, most trusts now, you're looking at, we're starting from with all the deficits that are being reported with a 5% zip in the figures we've produced now. And when you start getting into more than 5%, people don't deliver it, do they? So we get
well, I think it's very important these days. When I was in doing this stuff, it was always very important to make sure you came in on budget or slightly under. These days it's very important to come in, I think, with a deficit. It's just a question of how much
on plan. You just have to come in on plan, don't you? But it's still quite brutal now at 5%. So if they started adding another couple of percent onto that, people just won't be able to
can't do it. No. Okay, right. Let's talk to our audience. Where's the one? Diana Lewis. Good evening, Diana. Thank you for joining us. It's interesting this, because this is right up David's street, I think. So I'll come to Anne first. What help does secondary care need from GPs? Are they doing a good job? What else could they be doing? We know over 90% of care is undertaken by GPs. That's true, for less than 11% of the budget. You might like to add that, Diana. And what's the future of GP land? Now, I know, David, you've got this all sewn up in Wolverhampton. So let's go to Anne and see how she's getting on, and then we'll come to you.
when I read your column, Roy, sometimes you recommend things to read that turn out to be really interesting. You know, one of the things I was reading about was, you know, that day in the life of a GP. And what was really interesting was some of the issues. It was a female GP. Some of the issues she raised around types of things that, you know, GPs typically see in a day's set of appointments. And it was about normalising. Just ordinary life sort of thing. It's medicalising ordinary life. So lots of people coming in with things that, you know, in the past they wouldn't have had to see. So I think their kind of workload is expanded to cover, you know, kind of some things that perhaps in the past weren't even regarded as illnesses, if you like.
Yeah.
So
that came out in Claire Fuller's report as well, which I thought was a really good report.
Yeah, it's an interesting point. So I think that they're as overwhelmed as we are, but perhaps they've kind of altered the dial a bit in terms of what they're required to cover and what they're expected to cover by the patients. So and obviously all of the issues about, I was reading an article about, you know, this partnership model and where does all that fit. We did almost get into, you know, we have one GP practice only in our trust because it happened to be on our site, and then everybody left, so we actually had to pick it up and run it. So kind of got experience of, not like David running loads, but I do run one GP practice, and it's been an education. But yeah, I mean, it's the answer's got to be in having some of those services delivered by other kinds of people, which I know is the model PCNs have looked at, and which is the received wisdom. And we've done a lot of it in our one GP practice about it. You know, it hasn't always got to be a GP. There's any number of others.
You're right. I mean, there's no question about it, is it, David, that the gold standard is a GP, family practice, consistency of care, continuity. Everybody knows who you are. But it ain't going to happen because we haven't got enough GPs. 240 GP practices closed last year. God knows how many is going to close this year. So the answer seems to be vertical integration, David.
Well, for those that don't know, I started vertical integration in 2016, and we've acquired a number of GP practices. The one thing I've got to say of why we've been successful is I have transferred significant resource into those practices in terms of staffing, physiotherapists, pharmacists, etc., etc. So, you know, it is about the workload of the GPs. And as I'll quote Simon Stevens, actually, there's a flaw in the 1948 model that, you know, GPs are independent contractors.
Yeah, that's all Bevan could do, wasn't it?
Yeah, but, you know, it's also manifesting itself now, because the difference of what I can offer is I can offer portfolio careers to GPs where you can, you know, work 6 sessions in primary care, and you can have 3 sessions in the hospital working in the specialty of your choice.
Yeah,
you know, and
that makes a big
approach.
difference. Yeah. Would you like to see? Sorry, Anne, go on. Yes.
One thing I'd really like to say, just a practical thing, is you know, people get directed to pharmacists in the high street or whatever. That always goes up, but they can't really prescribe. Kind of, you know, it's like, I think that the limitations that we enforce in this country.
Yeah. I must tell you, and I'm sorry to cut across. I had a really good conversation this morning with some Welsh, with the leader of pharmacies in Wales, because I made some rather disparaging remarks about pharmacists and selling sun cream. And so he rang me up and quite rightly told me off. But in Wales, you know, they got IPs, what they call independent prescribers. The government have funded independent prescribing courses for pharmacists who do this diagnostic course as well. And they funded that. And this is the interesting thing, each pharmacy has access to the patient's GP record from the pharmacy. I mean, that's a huge step forward, isn't it?
I mean, I can tell you, Roy, and NHS England did give me a lot of support in the early days of vertical integration, but they also made me write to every person on the list before I acquired the practice to say, and I'll make it up, you know, from the 1st of April, the information the GP's got on you is going to be shared with the hospital, and the information the hospital's got on you is going to be shared with the GPs. And we used to get 10 or 15 letters back questioning why don't you do that already?
It's a lovely thing.
It's like going to Lloyd's banking it and drawing 50 quid out and going to the cash machine at Barclays down the road, and they didn't know you've just emptied your account.
Yeah, it's ridiculous. And so this independent, and I tell the other thing, and just as a quick aside, you might want to make a comment on it, and that's non-medical prescribers like OTs and physiotherapists. And it costs the individual for 3,000 or 4,000 quid to pay for this course, which is like essentially like daylight robbery when they're working in a hospital, and it takes forever to do. I mean, we do make it difficult for ourselves.
We do, and other countries don't do this, and I mean, we all know, don't we, that pharmacy knows loads more about drugs and stuff than doctors do, and I agree with David about you do need the medical record, but even quite really simple things. I've taken relatives to pharmacies who say, oh, you need this, but you'll have to go to the GP to get it prescribed, and then you go to the GP and get it prescribed.
And it's the same with the physio, isn't it? You've got back pain, they do your physio, but you have to go to the doctor for a script. We need to change that. Okay, listen, I'm going to go to, where are we now? David Brewster. Good evening, David. Thank you very much for your question. I like this question. He said, if you could stop everything for 24 hours and you had the power to fix one issue, what would it be? David.
I think the one thing that I would want to fix is, that the cost of living crisis and the impact that is having, because, people do not leave their financial problems at home when they come to work. And you can see, lots of stresses and strains on people, and also fear as well. That is the one thing. So
there you go. Now that David Brewster is an example of root cause analysis at its best. I guess you'd say something similar, Anne?
I'd like to solve the social care crisis, because it just worries me how many people out there don't get the social care that they need. And, the kind of crazy situation we've got whereby, we've got all hundreds of beds filled with people who don't need to be there. It's a huge cost that entails, and the opportunity cost of not getting the patients in who need to be in them and holding the ambulances up and all that, for the want of maybe, somebody just getting a home care package. Somehow that, perhaps if I could change David's question to, if you'd had a magic wand, what would you first apply the magic wand to? That would be the thing I'd apply the magic wand to.
Okay. I'm just going to take a moment, if I may, for a commercial. We've got, of course, the IHMSC's annual conference, which is coming up. You can register for the conference, and Jade is standing by to post a link with instructions. So you'll see that in the chat column in a minute. So Jade is going to post a link. So we'd like to see as many of you as possible at our conference. Now let's just scrolling back. Where's the other? This is. Now, there are one or two typos in this, Paul Batchelor. Good evening, Paul. I hope I read this right. The discussion is centering on healthcare workers. Is there any merit considering something about how all people can provide care, and how should it be taken forward? Not quite sure what that means, David. It's a good start of a question, but I think, can you make something of that, David?
Maybe it's around, if you look at the numbers of people who, in the last 3 years, over 50 years of age, that are no longer in full-time employment, they've taken early retirement, they're doing something. I think there is a lot of people who have taken on caring roles.
That's true.
That is, maybe the thing to think about there going forward is, what allowances are people going to be given in monetary terms to continue to provide those caring roles.
That's true. And in Germany, if you're a carer, a relative carer, you do get paid, and you go on courses.
I won't name the country in such a public meeting, but certainly we found with some international nurses that we recruited that they were qualified nurses, but they did not provide basic care in some cases, because in their country the basic care was provided by the families going in, washing the patients, and also providing food for them.
There's loads of evidence of that. I remember talking to Mark Britnell when he wrote his book about international healthcare, how he said, in the Middle East, the Far East, and those countries, emphasis on.
I'm not saying we should do that, by the way. I'm just saying.
Well,
that,
I mean, I think, as I say, in Germany, they actually pay relatives to do it, and they send them on courses how to do it properly. And there's a question here from Pauline Boyles, if you'd give us your thoughts on this. He says, if you were in charge of the total health and care budget, what would you do over the next 5 years? That's quite interesting, I think. Over the next 5 years, that's partly running up to an election. So there's going to be a few quid floating around. There usually is.
Well, I'd definitely sort the social care, healthcare.
Yeah, that's your big thing, isn't it?
I would definitely do that. But I suppose in terms of other things, I mean, the bureaucracy of the NHS drives me mad. I'd love to see, again, that being reduced. I do think we waste a lot of money in the NHS on bureaucracy and tiers of, things going on above. And as I go through this transaction process, that's just it's a kind of crazy process that, and you wouldn't make it up if you were trying to make it up. So I'd like to see, better regulation, because we have all this regulation and still things go wrong. So to get a regulation that kind of added value and didn't just kind of take a lot of time up, and when something does go wrong, it's all I think about, well, how did that go wrong? We didn't see it when we've been inspected and what have you not. So better regulation, less bureaucracy, and sort out that interface between health and social care, and pay the staff what the wages they deserve.
Well, look, listen, we're up against the buffers at times. We've got about 4 minutes left. So just give me a flavour, really, of what, you sit with your board, you do a bit of forecasting, you do a bit of thinking, trying to sort yourselves out. What are you thinking about, the next, 18 months, something like that? What are we we're under 2 years to the next election, aren't we? What do you think? What are you thinking about and that time and the challenges and what's likely to unravel? Do you want to go, David?
Yeah, I mean, I think the big thing, and Anne has already said it, it is around social care. And, if you're getting paid 10 quid an hour and you can get £13 to work in the supermarket, no wonder we've got a problem. And that really does need to be sorted ASAP.
But it's not, is it? There's no inclination to sort.
No, I mean, I can be really, you talk about the Department of Health and Social Care. That seems to exist in a sign at number 79 Whitehall, but it doesn't pervade outside that. And I've got to say,
the difficulty, David, is this. I mean, social care is fundamental. If you look at domiciliary care, which is our big problem, really. If you look at domiciliary care, it's small, often, not always, but often very small companies trading at the margins, really, of profitability. They don't have the gravitas. They don't have the wherewithal to train people properly. They don't have training budgets. I mean, some kind of consolidation in the market will be a good thing. And maybe in the same way that you've taken over GP practices, there's a lesson there to take over domiciliary care.
I'm looking at it.
How did I know? And what about you? How do you look at the future?
Yeah, I mean, there's some good things to look forward to. I mean, I do think some of the work we're doing collaboratively is so much better than where we were before, where we were competing with each other. And we're back to the values of the NHS that I used to so approve of. So it's patients are coming first, and organisational boundaries don't matter between the providers in the market, working together to get the best outcome we can for everyone. So I'm quite enthused about that, and we're looking at a lot of pathway stuff, and where pathways are fragmented, and we can improve them to make things better for the patients and shorter and faster, and therefore sometimes with better outcomes as a result of that. So I think there are some good things going on in the context, though, of if only we can solve all of these big problems that we've got, and try and just alleviate some of the pressures right now. I think the good thing about the move away from competition and into collaboration can only be a good thing. So I welcome that.
I think that's a really important point. Yeah, go on, David.
Can I just say, I mean, I think the one thing to bear in mind in all of this, I still thoroughly enjoy the job I do. And the biggest driver for me is I work with some absolutely fabulous people who are so committed to what they do. And I see my job as helping them to do better. But I just wish that, I'm happy in my job. I wish that all of the people that worked in health and social care were also happy in their job as well. and I'd like to get to that point.
I think that shines through in both of you, if I may say, Anne and David. You know, that's the role of the leader, isn't it? To create the time and space for good people to do great things. And, you know, it's been true for years and it's true now. Well, look, we've got to finish. Unfortunately, I wish we were sitting in a pub, really. We should be sitting in a pub having this conversation, shouldn't we? But maybe we'll try and do that.
Would you buy the drinks?
Well, I wouldn't go that far.
Come on.
But yes, all right. It's been enormously interesting and absorbing. I don't know where the time's gone actually, but thank you both very much. And you know, for what it's worth, can I add my thanks? I mean, I know how challenging the job is. I mean, and certainly it's much more challenging now than it's ever been. And thank you very much for what you and your people do to keep us all safe. So bless you both and thank you. If you've been watching, I hope you've enjoyed it. If you asked your question and we got it answered, I think we covered the questions, and it's just really now my job on the smack of 6:15 to hand back to John Wilkes.
Thank you, Roy, and I'll echo your thanks to Anne and David. I thought that was just sensational, just very absorbing, very insightful. We thank you both indeed. Just to draw members' attention to some other stuff coming up, we've got a major power hour on Tuesday next week, the 7th of March at 5 o'clock on leading neurodiversity in the workplace. This is an increasingly interesting topic, being more diagnoses of ADHD and such like. And we've got two experts coming along to address that. Do please sign up to that. And we've got a number of really good special interest group meetings across integrated care and digital health. But the big thing I also want to draw your attention to is our power hour on the 14th of March with Professor Brian Edwards, looking about how do we better manage mistakes. And this is in the wake, of course, of the contaminated blood scandal. So that will be a sensational evening. That
will be very good.
An absolute master of the topic. So do please sign in for that. And as Jade and Roy have already referred to, do please have a look at coming down to London to the Excel Centre 26th and 27th of April for our national conference. I think David is there speaking at what is the Health and Care Show anyway, and several other people will be as well. So yeah, it's part of the Health Plus Care Show, but we have our own dedicated theatre and event space, and we are really looking forward to that. Beyond that, once again, Anne, David, we are in your debt. Thanks a million. Roy, thank you as well. Thank you to the Queen of Virtual Conferencing, the one and only Jade Maloney, who keeps this all happening in the background very quietly and effectively. Nostar, everybody. I've got to say that was St David's Day yesterday, and I live in Wales, and we look forward to seeing you on the next one. Thank you very much. Bye-bye.
Thank you. Good night, everybody. Thank you.